take the next talk by Seok from Asan Medical Center, Korea. He'll be talking to us on management of failed DCRs and his technique of revision.
Thank you for the kind introduction. It's my honor to be part of this session. Yeah. Okay. So I'm going to talk about revision endoscopic DCR. As you all know, DCR is the standard treatment for complete NLDO. Showing a high success rate. However, 5 to 10% of cases, we need perform the revision DCR. For revision DCR, endoscopic endonasal approach is very useful as it allows for comprehensive assessment of failure causes and targeted surgery. Ideal ostium after DCR can be achieved by muscularizing the entire lacrimal sac, but in reality, it's not always easy to perform. There are many causes of DCR failure, and ostium scarring is the most common one. And membranous scarring can be formed over the ostium, or thick ostium scarring would be more common. Inadequate bone removal can result in high ostium causing some syndrome or small ostium. Now, other causes include distal canalicular obstruction or soft tissue obstruction by middle turbinate or polyp. Not surprisingly, there are many cases which are associated with multiple causes. So revision endoscopic DCR have to address many issues, including the scar and granulation tissue at the ostium and inadequate size or location of the osteotomy. So ostium scarring and osteotomy will be the most important essence for revision DCR. Revision DCR is usually very challenging because of distorted anatomy, difficulty in separation, and intranasal adhesions and increased bleeding risk. For successful surgery, it's important to evaluate the obstruction type, and obstruction pattern could be related with bony obstruction or scarring or combination. And for evaluation, preoperatively, DCG, CT, or CT DCG can be performed. And CT is useful to observe the osteotomy site. In this particular case, the lacrimal sac is still covered by lacrimal bone posteriorly, so it should be addressed. And DCG is important to see the obstruction, especially scarring pattern. So when there is pulling inside of the lacrimal sac, you can think about the possibility of membranous obstruction. But when there is no pulling inside of the lacrimal sac, you should suspect the possibility of common canalicular obstruction or thick ostium scarring. CT DCG could be very useful, which can address the osteotomy site and ostium scarring at the same time. Intraoperatively, lacrimal sac mapping is important to see the obstruction type, especially 45-degree up and down test is useful. And lacrimal probe is inserted through the canaliculus, and it can be angled 45-degree up and down, which correspond to the lacrimal sac or ideal ostium site. So when you encounter the bone obstruction, you have to do more osteotomy. When you encounter the soft tissue obstruction, so ostium scarring should be removed. The cicatrix should be excised around the internal common canalicular opening while preserving healthy sac mucosa around the CC opening. And flap suture technique is useful to reduce the granulation tissue formation or scar contracture. So you should enlarge the osteotomy site, and mitomycin C could be helpful for cases with thick ostium scarring. Adequate nasal packing is another important thing. And for cases of canalicular blockage, trepanation or serial dilatation is helpful. And silicone stenting should be performed all the time. And double stenting could be beneficial to maintain the patency of canaliculus. Synechial should be performed. And partial middle turbinectomy or nasal septoplasty could be useful, but not always required. So I'm going to share some cases, and this patient was referred for revision DCL. When you see the CT DCG finding, so you can see the thick ostium scarring here, and when it comes to osteotomy site, the size is not bad, but inferiorly there is an inadequate osteotomy site, which should be addressed. And there is a small spot or small space in the lacrimal sac which suggests some amount of healthy tissue inside of the lacrimal sac. During the surgery, you can see a very small ostium at the operculum of the middle turbinate, and after local injection, so lacrimal probe is inserted for lacrimal sac mapping. You can see the level of the common canalicular opening. I usually use a monopolar cautery for nasal mucosa incision to reduce the bleeding during surgery. And it should be about 5 millimeters above the common canalicular opening level. And nasal mucosa, which correspond to entire lacrimal sac, should be incised. And using a Freer elevator, the nasal mucosa is raised and exposing the lacrimal sac inside. And while the lacrimal sac is tented using a lacrimal probe, I usually use a keratome to make a vertical incision to expose the inside of the lacrimal sac. As a patient has a thick ostium scarring, using a keratome or cutting ethmoid, the thick ostium scarring can be removed appropriately. Then we decide to perform the flap suture technique to reduce the scar contracture after revision DCL. So this technique might be challenging at first, but with practice you can do this technique without any special instrument. And the posterior flap of the lacrimal sac is sutured to the nasal mucosa to make her wound healing clear. And you can see the small amount of healthy mucosal tissue inside of the lacrimal sac. And inferior osteotomy is enlarged. And the inferior portion of the lacrimal sac is completely exposed. And silicone tube is inserted. And as this case is related to the thick ostium scarring, we apply the mitomycin C for 3 to 4 minutes, followed by saline irrigation. Lastly, the nasal packing material, which is soaked in gentamicin and triamcinolone steroid, is inserted for packing. So moving on to another case, this lady was referred for the revision DCL. So when you see the CT scan, CT DCG, you can see the contrast pulling inside of the lacrimal sac, which correspond to the DCG finding, which suggests the possibility of membranous obstruction over the ostium. And you can see the thick synechiae between ostium and nasal septum. So we have to address this issue as well. So during surgery, as shown in the CT scan, you can see a thick synechiae between ostium and nasal septum. And using a Fourier elevator, the synechiolysis is performed, and the nasal septum is medialized to secure the enough space around the ostium. And after packing, you can see the ostium site well. And lacrimal probe is inserted for lacrimal sac mapping. Suggesting the membranous obstruction. And again, monopolar cautery is used to make an incision on the nasal mucosa to cover the entire extent of the lacrimal sac. Using a Fourier elevator, the nasal mucosa is raised to expose the inside of the lacrimal sac. And while the lacrimal sac is tented using a probe, so keratomy is used to make a vertical incision. You can see the enough amount of healthy mucosa inside of the lacrimal sac. And using a blade and ethmoid forceps, the thick synechiae is removed. And the osteotomy site is enlarged superiorly using a Kerrison plunger and power drill. And after that, you can see the inside of the lacrimal sac as well as common canalicular opening. And silicone stent is inserted and impure flap was made. And lastly, the packing material is inserted, which will be maintained at least 2 weeks to prevent the reformation of the synechia. In conclusion, there are many causes of DCL failure, and ostium scarring and inadequate osteotomy is most important. And for successful surgery, the cicatrix should be completely excised while preserving healthy sac mucosa, and flap suture technique is helpful. And osteotomy site is enlarged enough, and internal CC opening should be proper, and scarring and contracture can be prevented using many methods, including MMC, nasal packing, and postoperative care. Thank you very much for your attention, and I'd like to invite all of you to AP Supper's masterclass. Thank you.